Okay, looks like it's up. Okay. Okay. This is the Human Services Committee meeting for June 15th, 2017. The first item on the agenda is courtesy of the floor. Nobody's here. Next item is the update on the Grace-Dale Nursing Home. Thanks.
Okay. I'll go ahead and get started with the average daily census. We are at 662 for May. If you look at the previous year, we were at 667.6, so we're a little bit down, but we're still above budget of 660. We have maintained our census again since March 15th. We have been at 660 or above, so we are holding steady on census. With regards to our, let's see what we have here. There's really no other change. Everything else is pretty similar to what it was the previous month. Any questions on admissions? Yes.
Just a real quick math question here. So in April, the year-to-date cost per resident was $250.
$250. Oh, I hadn't gotten to finance yet.
Oh, I'm sorry.
No, that's okay. If there's no other questions for admissions, shall I move to finance?
Please.
Okay. All right.
All right. So in April, the cost was $250.66, and then the cost per day increased from April to May, but yet the average cost went down. How does that math?
Yeah, the average cost went down because it depends on the type of resident that we take in. If we get more people who are on Medicaid, there will be a lower cost as opposed to we have somebody who is private pay.
Right, but wouldn't the month of, and I realize it's not much, but I'm just trying to figure out how the math doesn't work out here, because the cost per day in May was $237, which was an increase from $219, but yet the average went down.
The cost and I see. Okay, cost per resident day was $237, but the average went down. Yeah, this is also, just so you know, an approximation because all of the financials are not in until the end of the month. So, in the following month is when you'll get the true number. I don't know if you noticed, but sometimes the numbers change if you hold on to these things because Peter will get me the actual when all of the information's in. So I do apologize for that. So that probably is why you're seeing that.
Okay.
Any other questions on finance? I will point out on our case mix index, it does say 0.9 again, but I just found out today, and of course it was too late to get it to you in advance, that our case mix index is actually at 0.91, not 0.9. Our goal was 0.95, but we're still moving up in our case mix index, which is a very good thing to know. Any other questions on finance before I move to Medicare reimbursement? Okay.
Yeah, quick question.
Yes.
What do you think is driving the increase in the case mix index? What are you guys doing?
Yeah, what we're doing is because of the fact county homes used to basically be on the system where you'd go up just a certain amount to be able to capture the reimbursement that's ended. Now we're like every other nursing home. So what we have to do is capture each and every skill that we get on our residents, which means we have to be more diligent on what we're finding. We have to stay within that period. So we're really working with our rehab company, Advantage. We have a woman by the name of Kathy Kemmerer. She is a CMI expert, and she was a former MDS coordinator, and she's really rallying everyone together, along with Sue Edwards, too, to get our case mix index higher. And it is more work because you have to really capture everything. Anything you let slide will do that, so you have to be hyper vigilant with what you're capturing. So that's what's doing it. That's what's driving it.
Okay.
I have a question. question, sir.
Yes, sir.
I have a question about the days in account receivables.
Mhm.
How come we're approaching basically 4 months to collect money? How come that's going up?
Yeah, well, with that, I mean, we are having some issues with regards to payment, but we are working diligently on it. We do have our meetings, and actually, I have taken a personal role in it and working to get payment. I will go ahead and kind of be the last resort before collections, where I will go ahead and speak to them and say, look, this is due, this is what you owe, when can we expect payment? And we have done well with it, but it still continues to be an uphill battle.
I mean, with 662 people, and the average is 104 days right now, and you have an asterisk because you don't have this month's. I mean, if you do this kind of billing all the time, you know, some people are probably out, you know, 6 months, 10 months, 12 months. I mean, what is the worst case and what is the typical? I mean, do you have people that pay every month? What's the average? Like, or is everybody late?
No, for the most part, you do have people who do pay every month, but you will have those exceptions where it's increasing because, let's say, they haven't become Medicaid eligible, so the private pay is going to build up until we can get the Medicaid. You have to factor that in as well. It's not all collections, but in the collections aspect, we're staying on top of it and making sure that we're involving our law firm to go ahead and get the money that's due us if we find that we're not able to do it on our own. It's like I said, it's an uphill battle, but we continue to work on it.
Thank you.
So you'll see differences, though, when like people get Medicaid and then you can wipe out the actual, you know, debt that's being accumulated. We just have to wait for that until we can get our approval. So
Medicaid's retro?
Medicaid can. Oh, I'm sorry.
You may finish this
Yeah,
question.
Medicaid is retroactive to the date of application. Yes.
Okay, so, and it could take, what, 6 months to get Medicaid eligible? I mean, you know, we're talking the government here.
It can at times. Yes.
And that was what I was going to ask. How long does it take for Medicaid and Medicare receivables to come in? Is that an average of 3 months?
At least, yes.
And how many days? 104 are you looking at? So
Yeah.
3 months, 90 days. So that's another factor.
Right. Thank
Go
you.
ahead.
Okay, any other questions on finance? No? All right. Just going to move, into Medicare reimbursement. In terms of nursing, our RN, LPN, CNA overtime is slightly higher in May due to open positions which are actively being filled and also due to retirements. We have had a lot of retirements. On the upswing, a lot of people who have retired are coming back as nurses, as part-time supervisors. You know, so we can utilize them in that respect, even though they do retire.
How does that work? If they're retired and collecting a pension, how do they come back and work for the county?
Well, I think my understanding is that, oh, it comes out.
They are able to do that either through the per diem pool or as a part-time employee. And once again, we pay attention to the 1,000 hours because we want to be sure that we are caring about the healthcare piece and making sure we're not using them over that 1,000 hours. That has been something that has been helpful to Graysdale because it's a workforce that's already trained and already knows the system. So we're very cognizant about making sure we follow all the personnel rules around that, but those are the two ways.
Quick question. So, in regards to nurses retiring and coming back, you said primarily in the per diem pool. At what salary is that paid out at? Is that a flat per diem salary, or is that the last salary that the individual left at?
I think,
Hourly
yeah,
salary.
it's a flat, yes.
So it's a per diem salary?
Yeah.
Just curious.
Yeah.
Okay.
Okay, any other questions before I move on to agency? Our agency costs are down. Again, it is an approximation, so that's why the numbers are the same, but you will get the correct numbers next month. But, of course, when overtime goes up slightly, agency will go down, and you do want that. If you have to have that, you'd want that because agency really, they don't know the resident as well as someone who works overtime. And agency costs more than overtime. Okay. If I could move on to the second page of compliance risk on the second side. There were no complaints for the month of May, no visits from the Pennsylvania Department of Health, so there were no deficiencies. Okay, quality measures. Any questions about compliance? I didn't think so, but I'll ask anyway. Okay. Quality measures were still higher than the benchmark with decline in activities of daily livings and antipsychotics. With regards to a decline in ADLs, our contracted therapy company has completed documentation training for all CNAs to properly reflect if a resident has true decline in their activities of daily living. In addition, our medical director, Dr. Lumser, has established an antipsychotic prescribing and gradual dose reduction protocol as per the new CMS guidelines for all primary care physicians and psychiatrists, which begins June of 2017, which is this month. Short-term pain is slightly higher in May, but still below the benchmark. This is due to an increase in number of residents with pain on admission. Facility-acquired infections are also up from 81 to 94 due to residents with allergies who are already compromised with other respiratory issues such as asthma, COPD, etc. In comparison, as of May of 2016, the facility-acquired infections was at 92. So it's kind of hovering around the same amount as it was a year ago. Any other questions on quality measures?
Yeah, I have a question.
Yes.
That was kind of quick.
Oh, sorry.
But Dr.
Holumser?
Can we spell that?
Oh, H-O-L-U, M as in Mary, Z-E-R.
Holumser, okay. And you said that Dr. Holumser has created a protocol based on
CMS guidelines
for the gradual reduction in antipsychotic use in the nursing home.
Correct.
And you're saying that that's going to take effect on June 1st.
Right. But we've already had decreases in our anxiolytic or anti-anxiety medications, which is bringing that whole antipsychotic number down. A lot of anti-anxiety meds like Ativan, etc.
So what medications are actually in this antipsychotic medication utilization measure? Is it anything that alters the brain, or is it just an antipsychotic?
Well, anything that falls under the umbrella of antipsychotic, the anxiolytics, like I said, the anti-anxieties, antidepressants, all of those medications, like your Risperdal, your Haldol, your so many, and Ativan, Xanax. There's many medications.
It's kind of misleading the term here. Then it should be psychiatric medications. It's not psychotic, but anyway. Is there any way we can get a copy of that protocol?
Yeah, I did give it to you guys the month before, but I'll give it to you again. It was his proposal.
Okay.
I'll give it to you again, though.
I don't remember getting that. Did we get a copy of that?
Yeah, they had spent some time on pain management,
Okay.
and part of that was the protocol.
All right.
Yeah.
Can I get another copy of that?
There was a lot of papers that I gave you that
Yeah.
time. That's when you asked me to give it to you ahead of time, so that's
Okay.
probably what happened.
The other thing I want to know, and we mentioned that at one of the other meetings, is would Dr. Holumser be willing to come in and talk about?
I could speak with him, sure. I'm sure he'd be happy to do that.
If he wants to give us a presentation on how we're kind of working on this particular quality measure, since it seems to be kind of a drag on our measures.
Yeah. I can tell you he'll probably also talk about a program that he got a $10,000 grant for, Music in Memory, which is utilizing music to stimulate memory, long-term memory in individuals to kind of prevent from utilizing antidepressants, for example, or things that make them depressed. They start to hear this music and it gets them going, and without the use of medication at all. So I'll make sure he mentions that as well, because he's very proud of that program.
Is that like a $10,000 grant to buy like some radios and stuff for that?
Well,
for
it's
the home, or-
actually, it's those, like the iPads.
Okay.
With the music or the I don't know the latest thing. I don't listen to a lot of music, so I'm going to fail at that. But it's generated through that. There's songs that are downloaded specific to the residents' tastes, and then they play it for them to kind of stimulate. It's actually a wonderful program. They did a presentation on it, and it's actually the first nursing home I ever worked at. It was the first nursing home to do it in Brooklyn, New York, called Cobble Hill, and they really had a lot of success. So a lot of nursing homes have been following with it.
That's great.
Yeah, it's a
It's
wonderful
great.
program.
Yeah, I'd like to hear you follow up with that.
Oh, sure, definitely. He'll be very proud to talk about that.
You mentioned physical therapy with declines in ADLs. I see that decline in ADLs has kind of gone up significantly over the last 2 months. Any thoughts on that, or is it because you're taking on more physical therapy patients?
No, the coding that the aides were doing was not 100% accurate. They thought that with a certain type of individual, they were supposed to code at this number,
Okay.
and they actually were supposed to code at the other number, which brought it up when it should have brought it down. That's what the need for the retraining occurred. And since that retraining, you're going to start to see it down. But as I talked about quality measures in the past, it takes a while before you finally see it, but then it will happen.
Yeah.
Yeah, so that's been corrected with the aides. They just had a misunderstanding. And again, that was with the help of the therapy company to educate them and show them exactly how they're supposed to code.
So you think this was mostly a coding error?
It was a coding error, yeah.
And how long do you suspect that coding error was going on for?
I couldn't tell you exactly. I know that when she came on, I think like 1 or 2 months ago, she noticed it. And she saw it because the aides were under the impression that they were supposed to code it that way, not realizing they didn't have the right information. So it wasn't intentional. It just happened.
Okay.
But they do have the correct information now, and they're coding exactly as they're supposed to be.
Does anybody have anything else for quality, Mr.
Yeah,
Phillips?
So our quality measures have always been 1. And, and we're overall now at 1. And really we talk about this all the time, I feel. What really is hurting us is that regulatory compliance, right? We were at a 5, last year, and that 5 was enough that it pulled the 1 way up, and we ended up with an overall at 4. I remember going up and celebrating that. Just talk to us again what we're doing to get our regulatory compliance numbers back up to 5.
Yeah, I don't think we were ever at a 5. I think we were at a 4 because the quality measure is always at a 1. So when you're a 1, you always lose 1 star.
Oh, I'm sorry. When
Yeah.
I said we were at a 5, I meant for regulatory compliance, we were at a 5.
Right.
Yeah. And so we're at a regulatory compliance at a 5. Always had done badly in quality measurements.
So brought
at
the overall
1.
down to
So
4.
that brought us up to a 4 overall. So the highest we've ever been overall was at a 4, but we were, for a long time last year, almost all last year, at a 5. And now because of that issue in last September, we're down to 1. So just let's talk about what we have to do to get our regulatory compliance up to a 5. Like, what's our get well plan for that?
Well, our Get Well plan is basically to be on top of the environmental rounds because that's where the regulatory compliance is mostly made from. So I have the supervisors doing monthly rounds, of which I do a surprise round myself, which could be at any time, any day, and any unit, to go ahead and check to make sure that they are staying on top of it. That is part of our quality assurance performance improvement plan, where we look at the trends of what's going on the unit so we can go ahead and correct them. And we make that supervisor responsible so we don't have a lot of the deficiencies that could have really been prevented, because that's kind of what brought us down in conjunction with the complaint on the G. So although we were 4 for a long time, because the quality measures, not quality measures, the STAR report is reported every quarter, you have to wait until the quarter, and then we just kind of fell in that point at the beginning of the year, where all of a sudden we were like 4, then we were 3, then we were 2, and then they took away 1 because of the quality measures down to 1. So it all happened kind of quickly between the months of January and April, where we went from 4 to 1. And that's because they had to play catch-up because of all the data and everything that's reported in the following quarter, which was after the 4th quarter of 2016. And in 17 is when it all showed up that we went down quickly.
So, so there's two things going on. How well we do on our surveys and our compliance. And, so I understand that you're taking measures to have the quality assurance in place for that. Then another issue is, which is beyond our control, is the aging off of that G rating. And my understanding is from talking to you before is that G rating won't be aged off this year. We'll be probably carrying that into next year.
Yeah, but it'll be at a reduced rate,
Yeah.
like what I talked about with the driver's
Yeah.
license.
So do you have an idea if we, and I don't know if this is like, just, it's a complex question, but if we did well on our ongoing compliance, and if the G rating aged off, when do you think we would be able to leave the regulatory compliance of 2 and bring that up? Do you have an idea when that would be, like when we could go from a regulatory compliance from a 2 to a 3?
Yeah.
Can you forecast that? Do you have an idea, like, do you feel comfortable that we would be able to do this at a certain time?
Yeah, with no complaints and survey of zero deficiencies, you're probably looking at about a year
Okay.
to go from that. When we get our quality measures up, which we're in the process of doing, we should immediately go to a 2, and then the 2 to a 3 will probably take about a year, and then 3 to 4 might take a little bit longer. But it's all dependent on if there are no anonymous, even if there are anonymous complaints, there are no substantiated complaints, and that our deficiencies will be at 0. Now, the good thing is, unfortunately, like I said, our former director of nursing, Beth Berklight, had retired, but we do have Janet Harrison coming in on July 10th. And again, not only with 25 years as a director of nursing for Cedarbrook, which is a 5-star facility, she is also a state surveyor. And she knows the ins and outs of exactly what we need to do. So we're really excited because we know she's going to bring a lot of knowledge and expertise and some good ideas to bump that up, bump that star rating up.
Because just reiterating the obvious, but because of that G aging off, it won't. We don't have a line of sight to getting to a 2 until next year. Overall.
Possibly a 3 if we get those qualities up. So you see, if it goes to a 2 on the quality, overall it'll be a 2, and that 2 could become a 3.
Yeah. If you got it beyond a 1, that the quality measures above a 1, that would be something, because we've been a 1 forever in a day.
Yes, we have, but there's a lot of things going on, like I said, with our medications and our pain that we're staying on top of, so we are going to be seeing that quality measure go up to 2.
Yeah, I'd love to see that.
Yeah, and I'll be happy to announce it.
Thanks.
Sure, no problem.
What's up, guys? For the regulatory compliance, who does it? Is that an internal assessment we do, or because we don't have someone coming in monthly from the state to do that? So
No, it's an anonymous system where anyone can call the state and say, I'm not happy with blah, blah, blah. I want you to come into Graysdale and investigate this. And if they feel that there is a need based on their complaint, then they will come into the facility and investigate it. And if they see that there is nothing wrong and that we've done nothing according to what the individual or people are accusing, then there will be no substantiated deficiencies. So it could be at any time, any day. They just show up.
right. All right. Yeah. Okay.
Okay. Any other questions?
Ray,
before? Yes.
why don't you send out the website that describes the reporting? I forget what it was. Right, I was asking you about the G rating,
Right.
and you sent me a link, and I studied that link, and that link helped me not only understand the G rating and everything, but it really helped me understand a lot of this report.
Okay.
So why don't you send that out to everybody? It's something that they can go out and they can get familiar. I mean, it actually describes what you've been telling us about that incident and everything. So if you can, send that out to everybody. Maybe send it to Linda, and she'll send it out to,
Sure.
to folks.
No problem. I'll
And
take care of
it's
that
a good
tomorrow.
good one to have on your marked on your browser.
Yes. Okay. Anything else before I move on? Okay.
I have a couple more questions. Pain. I know it is a pain, no pun intended.
It's
but,
subjective.
Well, we're close on the short-term pain to meeting our benchmark. And we actually, according to this, we almost made it
Yes.
a couple months ago. It would be nice if we could meet the benchmarks on both pain measures. And do you surmise that that would actually help bring up the quality measures in
It'll be,
itself?
yes, it's definitely a component.
Yeah.
With short-term pain, that involves your individuals who come in short-term, the rehab, and it depends on what you get and what's happening, that can sway it. You know, we can't control, if someone comes in and they're on pain, and we're going to do everything we can, but they're starting at a point, then we're going to eat that, and that is going to increase our percentage. Just like if somebody comes in with ulcers, or somebody comes in with, any of the other deficiencies, like restraints. If they come with restraints and we're trying to reduce it, it belongs to us, so it's going to raise it, and then we're going to try to get it down. So each month is it's a battle.
Can we talk a little bit about weight loss? I don't think we've mentioned that one yet in this committee. Can you describe a little bit about that quality measure and why it seems we seem to be falling away from meeting that benchmark?
We're under.
Yeah.
Oh,
That's good. Yeah, we have less people.
I'm
with weight
sorry, maybe
loss.
I'm reading this wrong. So,
No, that's all right.
Could we, thanks for bringing it up, because I didn't understand the short term, right? So the benchmark is 19.6% of the people reporting, issues with the short-term pain, and we're at 17.4. So that's good.
Yes.
So that I think you're reading that the wrong way, also, Seth. Is default that?
okay, so
So the short term.
Maybe I'm
the
looking at
short-term,
this from the-
That's good.
I'm
That's
looking
not-
at this
that's
from the
not an
back
issue
end.
for us.
Okay, so
Yeah.
Yeah.
It's, you want, you know this, you want less people in pain. So
Yeah.
Right,
it's a-
okay.
It's a lower percentage.
Yeah, that's how, so the short-term pain, 19.6 is the benchmark, so those people are suffering short-term pain.
Yeah.
We're reporting 17.4%. So that's good, because we have 2% less people than the benchmark reporting pain. So we're good. So if I looked at that,
but we're not
I'd-
making the benchmark on long-term, is what you're saying.
Yeah.
So that's what me and you were discussing.
Yeah,
Is that
long-term-
correct,
Right.
Raymond?
Yeah.
Okay.
And in that respect, you do have people who, pathologically, they get older and they have issues, and there's increased amounts of pain, and you have to deal with that as they age in the facility. So that's also another thing that we have to, deal with and try to help them with. And again, pain is subjective. You can tell me you're in pain, but what your definition of pain is not what his definition of pain is. I had a resident one time, not in this building, just in general, he just touched her and she went, ow. But there was no indication exactly, there was no substantiation of the pain. It's just that's what she did. So it's a very difficult situation, but anyone who says they're in pain, you have to address it and investigate it, and the more people who say it, the more people will go on this percentage, and you have to address them.
and this is not maybe as a nursing home as much as a hospital, which has the same benchmark. That's the problem I have, is that a easy way to get a good number on long-term pain is to oversubscribe painkillers, opioids. And you'd get a better number, because the people would say, yeah, I didn't have any pain while I was in that hospital at all.
They don't know where I am. Right, yeah.
Well, it's called you're
Yeah.
feeling no pain. so to
I mean,
speak.
Senator Toomey is actually trying to get legislation
Yeah.
to change that, so that that's not such an important benchmark, because there's a big belief that people are over-medicating to get a better mark on here, but at the downstream is that you get more people hooked on pain relievers.
And you don't want that. You don't want somebody.
No,
to-
you don't want that,
Yeah,
no.
absolutely.
Well, Hayden,
not.
I did introduce the medical marijuana thing to counteract the opioids, but
You did, and that got through at the state level.
That's right.
You failed.
Okay, does anyone else have anything for quality measures?
I want to throw something out here because I don't know how much time you have in your schedule. I go up to Graysdale a lot, go visit, just to be with some of the people that handle these types of pains and the things they do. And I will tell you, it's an education, so that the types of people that are being entered into Graysdale it's a wild deck. You don't know what you're getting until they're there. Is that the best way to describe it?
Yeah, I mean, people are sicker when they come to the nursing home. They're not as healthy because then they would be in assisted living or independent living.
Right.
So you're getting the sickest possible person. And so, of course, your measures are going to go up, and then you have to get those measures back down again.
And I have one of those problems with teaching to the test as a former educator. Teaching to the test. You teach a kid about a test and you test them on it. That's all you do. Okay, kind of narrow. This is the kind of thing where you're looking at a number, but it really isn't. It really isn't. It doesn't exemplify the things that they're going through on a daily basis up at the facility. So it's just worthwhile to go talk and ask questions if you can, to some of the people that are treating some of these things. It's an eye opener.
Okay, any other questions on quality measures before I move on? Okay. Next thing is human resources nursing. Our turnover rates are slightly higher in RN, LPN, and CNA due to retirements and new opportunities for some, mostly retirements. And with regards to call-outs, they've increased slightly in April from 131 to May from 174. And, of course, you already know about the star rating. Any other questions for Graysdale? No? All right, thank you very much.
Okay, thank you for the update on Graysdale. Moving along to the third item on the agenda is the update from the Children, Youth, and Families Division. Mr. Dolan.
Did you get tripped by? You got Allison's?
One of those older guys that I was competing against tripped me.
Nothing wrong with that.
I was winning too many medals. Okay, the story, the main story this year for you is the number of referrals to the Children and Youth Division since 2014, which is when the Sandusky laws went into effect and several other laws that I'm only going to cover their titles for you so as not to bore you. But in 2014, we had 3,514 referrals. That's the beginning of Sandusky. The laws, the 23 laws, begin to go into effect. In 2015, we had 5,617 calls regarding children being in a possible dangerous situation. In 2016, we had 6,061 calls regarding children being in a bad situation. This year, up to April 30th, we had 2,502 calls, which are 387 calls ahead of last year. And if you times that out, and everything has been holding true, so I see no slow up. Probably when we end this year, we will have had 7,500 calls regarding children in situations. And I can tell you the staff are overwhelmed. It is, I've heard terms like apocalyptic, tsunami. I just use it, it's overwhelming. And I honestly, after doing this for so many years, feel so bad for my staff of them sincerely trying to keep up with these thousands and thousands of calls that are coming in. It is, and there's deadlines that we absolutely have to meet. They're set by law, so it's not like you can slough this off. You've got to do it, and I'll probably be coming to you somewhere in a year from now or whatever, because there's no way with the staff that we have that we can really do this well. I just want to, besides the 23 Sandusky laws, and I'm, again, not to, so you're not bored, here's some of the things that we have had to implement over the last 3 years. We had to implement a quality insurance assessment and readiness implementation at the agency. Fortunately, my administrative staff had the foresight that we had an offer from the Child Welfare Training Center at the University of Pittsburgh. There were 5 offers to 5 counties that they would send a team of 2 professionals out that would lead the agency in 3 different levels: management, middle management, and lower management, meet with them monthly and make recommendations to improve the agency. So this is in action, and it's very successful in that what we've been doing things, rather than from the top up, we've been moving things through the agency from the recommendations from the bottom to us. I mean, it's still the administrative team has to approve it, but these staff that are living this day in and day out are giving their recommendations, and we're looking at that, and it's keeping staff. Because the other thing is, it's gotten very violent out there, and my staff get threatened a lot. And there's several counties that they have so many vacancies. Luzerne County had 40 vacancies, and they basically bring in 30 or 40 people to interview at one time, and then ask like number 15, 22, 30 stay behind, and they hire that way. Just on Wednesday, I was up in Scranton. I was talking to the director of Monroe County, and she said she had 1 new employee last a day and a half. And she went out, and there was a rather large woman that started using think of the strongest language you could use on a football field, and started using it at the worker, and she was shaking her shoulders and shaking her fist and everything, and the new worker came back and wrote a resignation letter and said, "I don't think this is a field that was cut out for me." So those are the sorts of things that are happening. Another law that was passed was the Child and Family Services Improvement and Innovation Act, and that fits into your earlier discussion, but we have to follow psychotropic medication that is given to children, because children, Justice Baer truly believes that children are over-medicated, and I think they are. And the best place for us to follow that is especially the children that we have in foster care, because those medications we can control. And we send those in, and it's called a dashboard that comes back to us. And we send those into Harrisburg. We get the dashboard back, and if there's any red flags on it, the doctors out there have said, take a look at this. This child in your foster home might be over-medicated with it. So we have that in effect. Planning, another law, planning and services for successful reunification. Again, we are on top of that, and thank you to your voting for the family group decision-making unit, because that has kept our placements down. But we've been doing that, and we do placement decision-making, family engagement, meaningful visitation, resource and family parent collaboration, and then one with adoption is post-reunification, because the saddest thing over at the Human Services building is when a parent who had adopted a child comes in and says, you know what, didn't work out, here's the suitcase, take them back. And so we've been really, those are heart wrenchers, like when that happens. So we have that. There's a big one happening on Monday. There's the Child and Family Services Review. On Monday, the federal government is sending a team of 7 teams of investigators into Northampton County. Now, every 10 years, every state has to be reviewed. And the 2 largest counties, Philadelphia, Pittsburgh, were selected, and then by random, random drawing, 4 other counties are chosen. And
Lucky
we
us.
we won the lottery. So they kind of edged it our way, which it's a compliment, but like a pain in the neck. The regional office who oversees us had basically told the federal government, we have so many counties with federal licenses. We have 8 counties with provisional licenses, and that's not good because you can't collect federal money when you have a provisional license. They said they really only had 2 really good agencies in the Northeast region, and that was Northampton and Lehigh County to take a look at. So Monday morning they are coming at 7 a.m. and they are staying till 7:30, and they are doing that for 4 days in a row. And they are interviewing the caseworkers, the school teachers, the counselors, any of the lawyers, possibly the judges, anybody that touched that family. The investigation, the federal investigation teams are going out and taking a look at that. The scary part is, if Pennsylvania fails this, and we're the last county, they've been in 5 other counties. If Pennsylvania fails it, there's probably about $100 million in federal money at stake that will not come to Pennsylvania because Pennsylvania did not meet the federal standards. So it's a big, big deal, and we've been preparing for months with this. I feel, no, I'm not going to say it. I'm going to jinx it. So we'll see what next week brings. It's going to be a long, long day. I plan to get there at 6:30 in the morning and get everything set up for them. There's the Indian Child Welfare Act. I don't know if there was a law passed with that. And it's notification, this is for American Indians. Notice of American Indian parents and tribes of state proceedings involving children have the right to intervene. Placement preferences of American Indian children in foster care, pre-adoptive or adoptive homes need to be reported to the state. Active efforts to prevent the breakup of the American Indian family when parties seek to place a child in foster care or adoption has to be approved by the state and the federal government. And then the final one, the tribal right to intervene in state proceedings or transfer proceedings to the jurisdiction of the tribe. And believe it or not, we've had several of them. There's been some American Indians that situations that we had to place, and we had the tribe down here at the leaders of the tribe down here at the Human Services building going over the case and either giving their yay or nay on whether Northampton County can carry it out or they're going to move it to the tribal council to carry out. But that's a little one that you might not know. There's the there's Act 91 that was passed, and that's provides appropriate supports for transition of older youth that are moving into the community on their own. There's the Adoption and Foster Care Analysis and Reporting System. It's part of the Social Security Act. That's been added. It takes up a lot of time. I'm not going to go into details with these for you. One that surprised the heck out of us that we didn't think was going to happen that much, we even had the FBI do a training with us, is the Preventing Sex and Human Trafficking. And when the Philadelphia office of the FBI first got involved with this, they said, there's not going to be many cases like that. And to be honest with you, we up here said, like, probably not that many cases. Well, let me tell you, these guys, they recruit for the dance clubs and for prostitution, and where they hang around are the residential facilities where adolescents are, or this is how smart they are, and they figure out what schools they're going to, and if it is a needy youth that they can talk into working for them, they do that. And the FBI from Philadelphia covers this area, has been so overwhelmed that they're going to expand that unit. There are so many situations like that. When I was up in Scranton, in Tioga County, there was a youth that came in from the Chicago area, and her handler had sent her up to that region because it was getting too hot in Chicago that they could get in trouble. So they sent her up to Tioga County, and she's there at the bus station, and the workers are calling and saying, what the heck are we supposed to do with her? She just came in from Chicago. So it's happening. Act 115 adds additional things to do around involuntary terminations of children. And the president signed a change in the Child Abuse and Prevention Law called the Comprehension, Addiction, and Recovery Act. And that has intensified our work with infants born addicted to an opioid or heroin, and work with the mother if she has been using drugs before she comes into the hospital to give birth. And as Act 94,
I'm sorry.
which is
Sorry to interrupt you. Can you tell me what act was that again? The opioid addiction for infants. I always wondered if you guys worked with children and mothers who are born under.
a lot.
Yeah. Okay.
It's July 22nd, 2016, the Comprehensive Addiction and Recovery Act. It's called, its acronym is CARA, CARA.
That's great.
Act 9. The only reason I'm going through these is I just, sometimes you think, like, what the heck are they doing down there? And it's like all these laws are coming our way, and you're trying to even just handle the Sandusky stuff, and then, like, all this other stuff is coming on top of us. And it's like, oh, my gosh, how are we going to implement these things given everything that we're having just even from the Sandusky laws? There was another law passed on educational success and truancy prevention. Any of you who are school teachers, ex-school teachers, there is a new law called it's Every Student Succeeds. Every Student Succeeds Act. It's ESSA, E-S-S-A, and what it ruled, and this is, the schools are just starting to catch on, but what it rules is it allows a youth in foster care to remain in the same school even when the foster home placements are changed. So if we remove children from the Nazareth School District but put them in a foster home over in Bethlehem, we have to arrange with the school district that they are bused every morning from Bethlehem over to Nazareth, so they stay in their school. And that works with any one of the school districts in the county. And we only spent $50,000 on it with the schools this year, you know, shaking out the, sharing the transportation. But I can tell you, the schools are starting to catch on to this. So it's going to be a bigger issue in the next school year for us. Requires schools to immediately enroll children in foster care after a school move. Requires points of contact in every state education agency as well as the school districts. Requires plans for school transportation for the youth in care, and tracking of data of those youth that are in care. And then near the end for you, the county agencies must also consider the impact of President Trump's America First budget blueprint and how the federal reduction of funds will impact their county. So we're planning for any issues that we have with that. There's another law that was passed for the service delivery for lesbian, gay, bisexual, transgender, and questioning youth. And what we have to do with that is when the child, if we have to place a child, we have to ask them what their sexual orientation is. Or if you want to be a foster parent with us, when you're a foster parent, we have to ask you what your sexual orientation is and what your opinions are towards different sexual orientations. And at first I thought, oh my gosh, we're like really infringing on people's rights going into that much detail. But I was surprised when we were out at the conference with Justice Baer, and he got up and he had a really, I guess, activist group out of Philadelphia speak, and they want this to happen because they don't want they don't want foster families that want to fix the child because of their sexual orientation. So they want us to match up the child's sexual orientation to a family that's acceptable to that orientation. Then we have another law regarding heroin and the opioid crisis, and I would say probably at this point 70% of our cases are drug and alcohol related, and I would say that's a major part of our
Okay, thanks, Mr. Dolan. We only have about 5 minutes left. Does anyone have any quick questions for Mr. Dolan?
I just want to know how he can still stand up after all this. It's like I counted no less than 17, I'm writing down as you were going, no less than 17 new measures that you've had to deal with. So I have nothing but respect for what you're doing. How many people do you have left, or do you have to handle all this? And I know you said you're overwhelmed. What does that mean?
Well, it means that we're going full tilt, and I can guarantee you that you have employees that don't have any downtime with it. They're pushed every minute of every day.
Do you feel that you don't have an adequate amount of people that are covering certain things?
Ms. France and I have been talking about that, and I think at some point she might be coming to you about that.
Yeah, because I mean, at the last time you came here, I think about a year ago, you had mentioned similar conditions that the regulatory environment is increasing, it's causing more work, and you had suggested, well, we may need to consider that. So maybe we're at that point.
The director from Lehigh County just retired last Thursday after 29 years. But I pulled Pam aside and I said, what is it? I said, what's the straw that broke the camel's back? Because everybody's saying they never thought Pam would retire before I retired. And Pam just told me, Kevin, she said, it's the numbers. She said, I don't have enough staff. We're not getting out there. Something bad is going to happen. It's just the roll of the dice. And she said, it's not, I don't want to be the director. It's not going to happen when it's on my watch, and I want to be out of here. So that's what we lost. 30, what did I tell you? 34 administrators, 37 administrators in the last 26 months. I'm on the state board, so it's just become, all of them in their exit interviews says it's not worth it.
You would think that that would be sending a message to someone who's in charge of all this. If you're struggling to keep up with the programs that they're issuing, someone should be taking note of that and saying something's got to give, something's got to stop.
We hope that they pay attention. Ms. France had ordered organized the legislative breakfast last week, and there were a number of state officials there. Councilman Phillips was there, and I think they heard the message. Now, I know they're probably at each other's throat around money down there, but we said, don't go passing all these laws and all the Sandusky laws, and then don't give us the money to carry out the job.
Yeah, that's-
Mr. Dolan, one more question if you don't mind, and then
I'm sorry, Mr.
Appreciate
Dolan.
it.
When you first started talking, I had a couple questions, and I think you touched on some of them. What's your turnover rate?
Maybe 20%. I think right now I probably have 10 vacancies. I was saying, I feel like, I don't remember if you know an old-time movie called Gallipoli, that what's that?
It was the invasion of Turkey
Yeah.
by British
with-
troops.
and-
Mel Gibson, right?
Mel Gibson, and it was kind of a sad ending, because what it was the general, he knew all his men were going to be killed, and it was trench warfare, and he ordered them out and over the trenches to charge, and the movie ends with them all being killed. And to be honest with you, I feel that's what I'm doing to the caseworkers. I'm just pulling them out of the trenches, sending them out there, and saying, I hope you make it.
Well, I guess that's my other question was, what's the replacement timeline? And I know from before when we talked about how long it takes for the county to fill positions.
Oh.
My suggestion is, it seems apparent that at the end of the year, Ms. France is going to have to come up before council and ask for additional staff. Is there any way to start those discussions much sooner? Instead of, it's June now, so we're talking probably 5 months. But in 5 months, if we can start opening positions up, it just, I agree with you. You're getting hammered, and I think before months ago we talked about the average lifespan of a caseworker was like 2.5 years. You can't imagine what they see, and then you add the bureaucratic red tape on top of that. I'm just thinking more sooner than later it'd be better for everybody to start looking at increasing your staffing.
We'll have that dialogue. And Ms. France meets with me regularly, so we'll go over that. We just have to strategize, like what we're going to ask you and what areas of the agency we want the backup in. But it's come. And right now, I'm writing the 2018-19 budget. I have to look into the future for 2019 right now. This is what I send into Harrisburg on August 15th. It's the needs-based budget. And I'm going to do one exactly like this for 2019. And I have to figure out right now, for the money we're going to get here in Northampton County in 2019, I have to look into some kind of crystal ball and try to figure out whether I get it right or not for 2019. So we will do that.
Okay, thank you, Mr. Dolan. We have to adjourn this
Yes.
meeting, this committee. Motion to adjourn, and then we'll move on to the full.
Hey, Hey, Kevin?
Sorry, it was a,
Kevin.
I know Ken was, getting antsy,
Kevin,
but.
Kevin.
Yeah. Yeah, mine too. So we're going to say we recommend it. Yeah.
Were you a Hollywood Marine? Were you a Hollywood Marine?